Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
We can make edits. Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
We're going to talk a little bit end of life in melanoma care. Before we do some quick fires, you know, often when we do these, I feel like we should just both answer the question, but I noticed the last few times we've moved really quickly on to the recording. So you had asked me about guilty pleasures, and I basically told you I was a French fry eater, I think, and a TV watcher. What are your safe for work guilty pleasures? And then we can decide if we want to edit out the unsafe ones.
No. I don't know, really. I quite like junk food, I suppose. But that's boring, isn't it? Everyone likes junk food, right? All humans like junk food. I like listening to dance music, actually. How about that? You know, mainly at the gym, admittedly. But could you really call that a guilty pleasure? I'm not sure. Like old school, obviously, because, you know, that's an age thing, isn't it, basically? Like, you know, 80s, 90s dance music.
That's always a good
you know.
time.
Yeah, well, I don't know. Maybe this is just, you know, an old person's comment. I don't think I've got any other guilty pleasures that are suitable for public consumption, actually.
Well, so that brings us to the not safe for public consumption. I'll cut this part out, but you know, when my friends were...
Well, yeah, that's pretty interesting. That he felt like that was the sort of... Sorry?
I'll definitely cut that.
So I watched another recent South Park last night, and that was about OnlyFans. It was. Have you seen that one, though? What?
No.
So So there's two main themes. One of them is those crappy energy drinks that children all feel the pressure to drink, and then there's a subplot about Randy again, Marsh, who basically somehow starts like an OnlyFans site. And then he's like wandering around like naked below the waist, basically. And then, of course, his wife then starts her own OnlyFans site as well. And then he's trying to compete with her. Yeah. So, yeah, we'll need to cut that out.
Randy's wife gets a shake weight, and she's constantly using the shake weight.
What is that vibrator?
No, you don't remember these shake weights? So funny. Yeah, that's South Park is just too good. I think I didn't catch on to it until the pandemic 20 years ago. It wasn't my thing, and now I just think it's so smart and clever. That's the other reason you guys should come to Colorado. These guys have the restaurant here, Trey Parker and
Home of South Park. Yeah, one of the very first episodes, I think they're diverting a lava stream. It's like literally the first 3 episodes of South Park, and they divert it for some reason to Denver. And Denver gets like covered in a lava stream so that South Park can survive. Yeah, we used to watch it loads, but I don't know how many. There must be like 25 years of South Park now. There must be hundreds of episodes,
something like that. Yeah, tons. And they there was one where it was the human caterpillar. Do you know this? Ridiculous, just funny. All right, so you don't really have any other guilty pleasures?
No, not that I think we can talk about. Yeah.
Okay. All right. Well,
I think if I can't come up with any suitable ones, maybe another time, but nothing at the moment springs to mind. But, you know.
Okay. Oh, we're actually recording, so this is end of life in melanoma, and what does that look like? Maybe the first. I mean, there's a few ways we can think about this. We've gotten really fortunate in these years to have many lines of therapy. So I guess a pretty obvious question is, what's the minimal amount of therapy a patient should have? I mean, should they, I think we all agree a BRAF MEK patient should at least touch BRAF MEK for its capacity to control disease even for a short space of time. But does everybody need to have combination immunotherapy before we start talking, okay, we've used up all the good options? That we have T-cell therapy. Do we need to try to get people to T-cell therapy? At what point in your current practice are you starting to think or initiate end-of-life conversations with your patients?
Yeah. So, I mean, what's the sort of basic minimum amount of therapy? I think it's for most people with metastatic disease going to be an anti-PD-1 based regimen, which is usually going to be first line. And what that regimen is going to differ from patient to patient. But I'd like to hope you've sort of made your decisions about that then. And then, I feel like, and I say to the patients, we're treating with curative intent in that situation. Because we know that we can cure some people in the long term. So, but then if that isn't working, you do your first set of scans or whatever, then for most patients, at least if we just sort of put T-cell therapy to one side for a moment, at least in most patients till recently, you're then likely to be in a non-curative situation, I would say. Mm-hmm. And so, yeah, definitely for almost everyone with BRAF mutant melanoma, BRAF targeted therapy, that's going to be in second line. But I think in that particular situation, that's when I would start talking with the patient about we're moving now, transitioning, and not just me, the rest of the team. We have clinical nurse specialists here who kind of support and get to know the patients really well. We're moving to a different phase of treatment. And of course, the thing is, you don't know with BRAF targeted therapy how long it's going to last, although you get quite a good idea from what the patient looks like when they start it. And I suppose I do my best in that situation to try and help people understand, at least to some extent, what they're really going to be looking at then in terms of life expectancy. And this is never one consultation, obviously, but it's a sort of a transition, I think. And for someone I'm really worried about really bad disease, bulky, high tempo, poor PS, actually for many of those patients, it might just be a few weeks actually. And so I think it's part of the job, our job in that situation, to really provide that information to the patients. Not everyone may want to hear it, or they might want to hear it differently. But I think, if you then, and this is the classic thing, isn't it, with BRAF targeted therapy, quickly, they'll feel much better. But then a lot of those patients with bad disease are absolutely on the edge of a cliff. And I think that's the time to be having those conversations. And then the other bit, and before I stop, is about, are they symptomatic? Do we need support from our palliative care team? And we work really closely with our palliative care team here, both within and outside the hospital. And it might be that people aren't that symptomatic just then, if you see what I mean. But again, forming those links, especially at home with the community palliative care team, is almost always a good thing to do early on, in a sense, before the patient sort of needs it. So they've got those relationships. And it might be that there isn't anything to talk about then, but then there's a face and there's a system, and it might initiate people thinking about, for example, when it comes to the end, whether they want to be at home or in hospital, because all that sort of stuff, if you try and organise it acutely when someone's really sick, is very difficult to do. And then actually you end up not respecting people's wishes and desires. And so actually, it's uncomfortable, I think, for some doctors, and it's uncomfortable for some patients. But I think that's the right way to do it, as a very quick top line answer.
So I hear you saying after you make it, if a patient progresses past, or their cancer progresses past frontline, first line metastatic therapy, you in your mind have shifted now. I think cure is basically less possible here now. And because it's in your brain, you introduce that concept to the patient then, whether they're about to start BRAF MEK, and even if they'll transiently feel better. And if they're not BRAF positive, you certainly are having it just to level set again. We've gone from a potentially curative stage to a non-curative, and then you try to ballpark what life expectancy looks like. So you're having a goals of cure conversation early, which is exactly to your point. Waiting until the end to have it is probably the wrong time for everybody, for the system, for the patient, and then for the provider. And so, in the US, an early goals of care discussion is really encouraged within our first 3 visits with the cancer patient. So that might even be in the adjuvant setting. They're coming back metastatic. What I like to think is every time I scan a patient, if that scan takes us to a different phase in our care, we've gone from adjuvant, now we're metastatic, or we've gone from metastatic under control, now metastatic with progression. If that scan actually is changing our phase of care, then we have to readdress the goals of care, because we might have been in the curative adjuvant setting, now we've recurred. We might be curative still in frontline, 40, 50% of patients. Oh, now we've progressed. So when that scan changes, then I have another goals of care. If the scan upholds, what the last one, wherever we are in the journey, then I don't tend to have it every time. But an early goals of care discussion, I do like that. You said something else that I thought was important. Oh, it's about this idea that a BRAF MEC, a BRAF positive patient exposing to BRAF MEC might feel good transient, or might feel good for whatever period of time, but they're standing on the edge of the cliff. Do you explain it that way, that you will initially feel better, and then at some point the cancer will learn its way around these drugs? Or how do you bring up, you're going to feel better, but it's not going to last very long?
Yeah, I mean, I would normally say something like, this is a treatment that almost always will help initially. It's very rare for there not to be some benefit symptomatically or radiographically, but the problem with these types of treatments is that those responses do not tend to last, which is almost kind of the opposite of immunotherapy. And sometimes I actually say it like that. The good thing about immunotherapy, if you're responding, is often the responses are durable, melanoma, let's say. But it's rare they happen, but it's rare for targeted therapy responses to be durable. I think that's a sort of statement across cancers, actually. And sometimes we get surprised, and I'm sure I've got loads of patients in clinic who've been on targeted therapy for very long periods of time. Some of them had checkpoint inhibitors before, some of them haven't. Some of them had small volume disease at the start, and you might have thought, well, actually, this is someone who might be on treatment for years, but sometimes that's not the case as well. But I think you have to prepare people for the most likely scenario. And then if you end up kind of beating that, as it were, in other words, the person's on treatment for years and you hadn't expected it, yeah, exactly, then that's great. Although actually, in my experience, sometimes I've had patients who've struggled to adjust to that, actually, which is a separate conversation. But I think in a sense, as gently, I think, as you can, you need to prepare people for the most likely outcome and to have at least some idea of timing in as much as you're able to say that.
So you also said getting them connected to palliative care early. So in this country, we went away from calling it palliative care because there was a connotation. So A, is that the term you guys still use? B, are the palliative care teams and the patients receptive to an early meet, even when there's no symptoms to manage? Do they understand they're getting sent there because when you have issues down the road, you're already connected? I mean, is that a hard thing to sell to the system?
Mainly not, actually. I mean, I'd have thought 80 or 90% of patients are fine with that in principle. There are some people who are resistant to it. I mean, that's just, to some extent, maybe that's human nature and they sort of don't want to face it. But, I and we as a team would say to people, well, look, maybe you don't need this at the moment. But actually having those contacts, there's no downside to having that. And quite often, if it's a community hospice or something like that, then a lot of it's nursing led. They might ring a patient up and say, well, we've had a referral, you're kind of on our books. We appreciate that, you don't need us at the moment, but you've got our contact details. Yeah. And then if you like, as people are, we both work at cancer centres and some of the patients are a long way away, and actually trying to manage symptom control remotely is very, very difficult. And I think most of the time it's not great care. They actually need someone, a team who are close to them, who are kind of receptive. Someone can go around and see them if necessary. And again, when people are well, that's not a big thing. But once it's kind of getting close to the end and people have got lots of needs, there's no way you can really do that remotely, I don't think.
Right. And so then when it gets to that point where they're having more needs and maybe your therapeutic options are less interesting, certainly less durable, when you're switching a patient perhaps off therapy now to support symptoms and focus on that as the goals rather than treatment of their melanoma, what are the options you have? Do you consider things like nursing homes? Is it admission to a hospital unit for end of days? Is it home? Is it hospice? in an inpatient setting, in a home setting? What does that look like? And is it covered in England?
Yeah, so from a coverage reimbursement perspective on the NHS, that there's no issue there. And actually, I think, I'm not an expert on this, but hospices are funded differently, in fact, from other funding streams, but they're freely available to people.
Okay.
What's going to be right for an individual patient, it will completely vary. So, the wishes, obviously, of the patient and their family, number one. But then actually, number two, for better or worse, you've got the feasibility of someone being looked at home in terms of what their nursing needs are. And then this is when you start getting into some resource situations, because if you've got someone who's got very difficult or heavy nursing needs, often it's just not feasible for that to be delivered at home. Mainly that can be delivered in a hospice, but actually hospice beds are quite scarce as well. And the other thing is that most hospices in this country aren't really, or many at least, not set up to, say, do things like blood transfusions and blood tests. So in that situation, it really would be symptom control only. But there are patients where you might want to be able to do a blood transfusion or do some tests. So I think a lot of this comes down to conversation with their patient and their family about what their wishes are. Is that feasible? Sometimes people do end up in hospitals because that's the only, if you've got complex needs, with the best will in the world, you can't deliver that very easily outside hospitals. And that's not ideal, but that's the reality, I think, of some patients. That's how they die.
So it's interesting. I think in the US, we consider hospice to be a discontinuation of life-supporting or life-sustaining treatments. Maybe that's the wrong way to say it, because it's not that we're stopping life-sustaining, it's that we're out of those options of life, prolonging. So things like blood transfusions or antibiotic use, or even, medications that control cholesterol or things like that, those are routinely not done under hospice care, whether that hospice is at home, administered at home, and they pop in and check on you periodically during the week, or it's in an inpatient setting or hospitalized setting. So we have a real distinction between if you're getting blood transfusions or continuing dialysis or things like that, that's not really compatible with hospice coverage. So that's one thing. There was this interesting study I just saw that some University of Colorado colleagues did about Medicare services, what's covered towards the end of life. And really, it's this idea between Medicare Advantage and traditional Medicare. So when you hit age 65 in this country, you get a traditional Medicare plan has a Part A and Part B. And then Medicare Advantage is often considered, I think that's what we consider like this Part C. It's kind of this extra bit that you can kind of supplement. And so it was looking at, because of that additional supplement or compared to traditional, do you have different access to services at the end of life? Turns out Medicare Advantage patients were less likely to die in hospital than traditional Medicare. But if they got admitted in the last 6 months and then discharged, then they had a higher utilization of certain, healthcare resources towards the end. Anyway, that's neither here nor there, but it does make the point that if you've got a third party like a payer covering for hospice services, it's then challenging to get them to also continue to cover immunotherapy infusions, blood transfusions, lab testing. So they're sort of seen as under separate umbrellas. But, I'm curious in your take in the kidney cancer world and melanoma, BRAF MEK use towards the end of life is, even in the face of cancer progressing, often we feel that if you take away the TKI, the symptoms might actually get worse because the cancer has less control. The TKI is clearly not reversing the trajectory, but maybe it's slowing the slope of it. So as I say, it's a little bit like the boy with his finger in a dam. The dam is breaking, the water's coming through, but he's got his finger in. Pulling the TKI would be like the little boy pulling his finger. So we like to continue BRAF MEK therapy into hospice, but that's confusing because based on what I just said, it's a treatment and we tend to separate that from hospice care. So what we tend to say towards the end of life is that targeted therapy is really more of a palliative medicine. It's a pain medicine. It's a symptom management medicine. It's not really life-prolonging cancer treatment. How do you view that? Do you ever send patients to hospice or, end of life care on a TKI for either kidney cancer or melanoma?
Yeah, sometimes, I have exactly the same view as you, that sometimes these medications can actually be controlling symptoms. Obviously, it's difficult to prove, but you get a sense often from the patients. And I think the worst thing in the world here is having a fight with the patient or their family about something like this. And quite often the patients will think and say that actually it's helping with managing some symptoms. So in that situation, of course, you listen and you say, yeah, we'll do this. And then the reality is, for people close to the end of their lives, they'll get to a place where they're not really swallowing medications very easily. And then it'll sort of, in a way, nature will take its course. And I don't have any strong views. I mean, sometimes people have strong views, for example, about the administration of antibiotics. But, I think if someone's got an infection, let's say, which is distressing for them, then I would also regard antibiotics as a symptom controlling type of medication as well. So I'm sort of, pretty, if relaxed is the right word, or permissive, or about any of this stuff. I think you're asking the question: is this intervention? Is this treatment? Is this helping to control symptoms or not? And if it is, then why aren't we continuing it? That's my view. And in kidney cancer, we had this quite a lot with VEGF TKIs. They're oral medications, and you'll have people who've got scans that are worse, but it's controlling hypercalcemia. It's controlling hypercalcemia. And, Sutent, for example, we don't use it much anymore, but that was given 4 weeks on, 2 weeks off. And we'd be able to see very, very clearly on blood tests that the patients who were on the treatment, the hypercalcemia was being controlled, and then the 2 weeks off, the calcium would go back up again. And so for me, that's a no-brainer. Carrying on a treatment, it needs to be well tolerated. Obviously, you need to get the dose right. But I think there's a lot of grey areas here, and I think it's wrong personally anyway to take a strong view that certain treatments should or shouldn't be done in a particular venue.
Yeah, you're right. Antibiotics under hospice, it's not forbidden, but I like the way you said it. I mean, if that infection is bound to cause distress for the patient. It's interesting because there's a lot of asymptomatic pneumonias you can potentially pick up. You can induce sputum and find something, but really it's not leading to anything. So then you're in this weird space of should you manage it? Because then you can also end up in a situation where then the family says, well, how do we know if it's working? Do we do another induced sputum, a blood test? Do we do a CT? Do we do an X-ray to make sure? And, that may not align. None of this may actually align with anything we're trying to do, which is just make them comfortable. Putting them through more tests and whatever may not do that. Along those lines, what about, so you said, when they can't swallow, would you ever go so far as to put a feeding tube in and try to do any of these meds that way? Do you ever deliver nutrition at the end of life?
Rarely is the short answer to that. I mean, I think it depends on why they can't swallow and what the overall trajectory and situation is. If not being able to swallow anymore is obviously an end stage event, in the last days of life, then for me, that's just part of what people look like when they're dying. And so I wouldn't say we never feed, but we'd only really be doing it if we can see that there's a reasonable expectation, shall we say, of their life expectancy being, let's say a few weeks or months or something like that. Other than that, and we're always cautious about it, because once you start feeding someone, as you've just alluded to, it opens up a whole other set of issues. So I think if you are doing that, you need to be clear about why. And we would always have these discussions actually with our palliative care team and colleagues. This would be a multidisciplinary discussion effectively. I'm not making these decisions on my own. We're making them as a wider team, nurses involving the patient. And then you asked me an earlier question about this, which I didn't answer, which was the whole palliative care description. Short answer is yes. That's how we would refer to it. Sometimes we might say symptom control team as well, almost interchangeably. But the reality is it's palliative care. And I mean, I would take a view on palliative care that actually controlling symptoms is something we should be doing all the way along the journey. You may or may not need palliative care specialists to help you do that, but that's part of what our job is.
Well, and that's why I think there was a push in the US to change the name, is introducing that team earlier in somebody's journey with whatever chronic medical condition they have. It may not be a goal to palliate anything, just to manage symptoms. And so there was this idea that people connote palliative care with end of life, but not really. We're trying to introduce them early in a chapter where somebody has a chronic condition. So that was just I think, part of the movement to change it here. And it makes it easier to swallow to tell patients we're sending you to the support, symptom control team or supportive care team to manage any symptoms that you may not yet have that develops on treatment. I have 3 maybe final questions for you, hopefully not short or long, whatever works. One is, you said if a patient feels their VEGF, TKI, whatever, feels like it's helping, or they'll say, I know the scan has worse cancer, but I do feel better on this treatment. I feel like it's helping. Hypercalcemia aside, it's just a feeling they have. What about with immunotherapy infusions? Because many times the patients feel good after getting an immunotherapy infusion. They don't feel poorly. They feel, whether it's a placebo effect or just some psychological benefit, that I'm doing something to help. How do you switch that off if they feel that therapy is helping? So how close to end of life are you giving it? Do you have a metric that you guys kind of follow where we try not to give therapy within this amount of time of end of life, et cetera?
No, I mean, I think to answer that question, I think with checkpoint inhibitors, I mean, my gut feeling is that almost always when the patients tell you they're feeling better, you need to listen to that. But I think, and also I would generally give the benefit of the doubt, meaning if the patient and the scan aren't agreeing with each other, we would carry on treatment and see what the next scan shows. But let's say you've had 2 scans that have shown clear progression, then I would say to the patients, well, actually, no, unfortunately, things are worse. The longer you're on this treatment, you've still got the risk of side effects. And if it was someone fit, I'd be looking at other treatment options going into trials, things like that. I really don't think that's the right thing to do in that situation. And then this whole thing, which we talked a bit about before, and interestingly, a measurement in this country of, I guess, what we do as oncologists and hematologists who are prescribing anti-cancer drugs. One of the measurements that's widely used is death within 30 days of anti-cancer treatment. It's audited and things like that. And, it can be, I think, a measurement of whether we're doing things right, but there's so much heterogeneity, different types of cancer, different modalities of treatment. I think probably it started off with cytotoxic chemotherapy for solid tumours. The idea being, obviously, that if someone's deteriorating and they've got poor performance status, they shouldn't really be having cytotoxic chemotherapy for metastatic disease close to death. That's probably a reasonable generalization, I would have thought. But like we've been saying, especially with targeted drugs, I really don't think you can put that across the board and saying, actually, death within 30 days is a measurement of whether we're doing right by the patient and doing our jobs properly. So devil's in the detail as ever.
Yeah, that's making its way over here to some degree. Those metrics are definitely looked at. How close to, how close is there a claim for treatment, close to a patient's date of death. And then, like you said, there's also, unexpected things that happen, toxicities that lead to death. Well, then it was perfectly reasonable to give treatment. So these black and white measures don't account for all these variations. What about steroids at the end of life?
Can be useful. I mean, depending on what the problem is. I think a trial of steroids, if you think that there's a symptom or a constellation of symptoms that can be usefully palliated, is almost always worthwhile if there isn't any obvious contraindication. But I'd normally do a trial of steroids for a few days, definitely not longer than a week. And then actually ask the patient, do you think this helped or not? And I think if it hasn't helped, you should stop.
Okay.
And then I think if there has been some benefit, I'd normally try and trim the dose down to a level where you're getting the right balance. I mean, the reality I think with steroids is that there's lots of side effects. We talk about this a lot, Particularly I'm thinking about now insomnia or abnormal sleep-wake patterns, that kind of thing. It'd be rare to find a patient who doesn't get some of that steroid toxicity. So it's not as though that they're drugs without a potentially significant downside, and you'll get the odd person who's diabetic where steroids cause mayhem with their blood sugars. And then, in that kind of situation, you're thinking to yourself, am I really helping here? But I think a trial of steroids, it's often a very reasonable thing to do.
Somebody trained me, and I can't remember if it was an oncologist or a palliative care team during fellowship, but somebody trained me that, essentially a cancer patient should not die without steroids on board. But I think that's too simplistic a point of view. I think it's, as you say, without a trial of steroids. It doesn't mean they have to go all the way with steroids, but there's a lot of symptoms that a cancer patient will experience at the end of life: appetite, energy level, that can be boosted with a maybe singular dose of daytime steroids early in the day. It can help with maybe an appetite, but certainly it can have these side effects of mood, insomnia, as you're saying, the blood sugar changes. So it's not to be used at high doses, and it's not to be used wildly if it's not helping or long term. But a small, in our case, maybe dexamethasone 1 or 2 milligrams, the equivalent of prednisone 5 or 10 milligrams, but dexamethasone tends to give you that real strong glucocorticoid effect. That probably is worth trying. But I do like the idea that there are some things at the end of life where the natural body's capacity to sort of give us that steroid boost or that steroid euphoria each day that we just get to get through our day is gone. And then you could supplement this in a cancer patient with a very mild dose. But yeah. Okay. Last question is if there is any movement in the UK or Europe that you're aware of for medical assistance in dying. We call that MAID here in the US, medical assistance in dying. There's a few states that, have this where, anyway, it can be controversial. It can be turned into a political issue, but is that anything that comes up where you're, a patient may be able to invoke 2 specialists that say, we agree you've got something terminal, end of life is in the next 6 months. Here's your cocktail to be used on your own terms and time?
Yeah, so in this country it's still illegal, but certain parts of Europe it's legal. Netherlands and Switzerland are the main examples that spring to mind. Interestingly enough, there's actually quite a lot of strong feeling on this subject, which is kind of out there, as it were, in public. And I think this is one of the things that the new government's actually been talking about, in terms of legislation. I think the last time there was any major debate or discussion about this in this country was a very long time ago. And as you said, there's a lot of different groups here with different agendas, shall we say. So the other question, I think, because it would need to be legislated, it would need to be legal for it to happen, is, and now we are straying into politics, is that the incoming Labour government in this country of the last, today's the 31st of July, and the election was on the 4th of July, so less than a month. There's a big list of things that need fixing in this country, in almost every walk of life. Yeah, whether it's before it or not, I don't know. But I'm just pointing out that in terms of the things, in my opinion anyway, that need fixing in this country, you're in the dozens, actually. And where that is on the list, in terms of what the country needs and what people want, I don't know. I don't think, honestly, if you walk out on the street outside my office and you asked, 100 people, the top 10 problems in this country, I don't think that would get into many people's top 10, which is kind of a shame because it's important. But then we've accrued so many other major problems over the last 10 years that a lot of other stuff needs fixing.
Well, you also probably bring up a point that it gets us to kind of an unsexy conversation. Who wants to think about dying as that just is an uncomfortable thing for a lot of people to think about, but maybe just as in closing, do you find that the cancer patients are uncomfortable having these conversations about what the end of their life looks like? Do they feel like it's when you bring it up, it's, why are we talking about this? Are you giving up on me? Is it that kind of thing? Or are they very open and prepared and actually wanting to have these conversations?
It's really variable.
Oh,
Really
interesting.
variable, which I think is going to be shaped by people's own background, culture, religion, personality, family. That's one thing to say. London's sort of quite heterogeneous. There's lots of different kind of groups of people that live here. So you can't take anything for granted at all about that. And I think the other thing to say is that, again, you and I both work at cancer centres. So yes, we do have our own local population of patients, but then again, a lot of the patients are coming here specifically to get treatment for their cancer. So I would argue that there's a sort of, it's probably not the right thing to say, but kind of selection or ascertainment bias for the kind of people that we're looking after. Yeah. These might be the kinds of people who are really, reasonably and rightly looking for treatment of the cancer in a way that maybe not everybody would be, if you see what I mean. So I don't have a one size fits all answer to that.
Yeah. I think my closer to one size fits all answer is I don't find that a cancer patient is necessarily afraid to have this conversation. And you can just read the room, right? The way our incredible palliative and supportive care team trained, I remember this very clearly in training, is use very simple, few words and let them respond. Let their reaction drive how you take the conversation. If they're shutting down this conversation, then fine. You get that this is, they're not ready for this. If they're open and saying, yeah, I've wondered what it would look like at the end. Is it going to be painful? Am I going to be at home? Then you know where to take that conversation. So you just sort of let them guide you. I think if we as providers don't have these conversations, you wonder, where do people have it in their life? Are they having it with their priest or their religious group? Are they having it with their loved ones at home? It turns out we probably, dealing in this specialty that does, approximate the end chapters for many, many people. I do feel that if we don't make it a conversation that we become comfortable having and that we read the patient's comfort level and having it back to us, you worry that some of these patients will miss the window to have the conversation of end of life. And then it's upon them, and then it's a rushed situation. And so, for whatever that means for training our teams and our, upcoming next generation, we've got to make sure we at least make space for this in our visits.
Yeah, I mean, I would make maybe a broader point there, which might be controversial, is it just feels to me in a lot of quote unquote developed, quote unquote Western societies, there's been a lot of removal actually from death over the last several decades, which in a way is a positive thing, because you go back, 100 years less, death was an everyday part of life for most people.
Yeah.
And that isn't the case anymore, at least in developed, quote unquote, Western countries, not just Western countries. I mean, and so, I mean, I sort of see this a little bit, I suppose, in family and friends when, someone's sick and they're dying, and as an oncologist, the reasons you've just said, this is part of our job. Whereas for a lot of people, it might be the first time ever, and they're adults, they've had any kind of close. And I think in a way, I mean, it's good, obviously, that we've got to that situation, that death isn't daily part of life. But on the other hand, we've got a kind of almost, in certain segments, a collective kind of dissociation from the fact that, in fact, death is part of life, unfortunately. Right. And it's sort of, maybe this is too strong as well, it's almost like it's kind of been sanitized or brushed under the carpet for a lot of people, which actually I don't think is right. And I think when people are coming to the end of their lives and when they've died, and you see this obviously in other cultures still, actually, yes, it's sad, but it's not automatically just a bad thing. This causes celebration and all sorts of other things, which for the whole of human history up until very recently, that's just how it worked. We kind of lost it.
I listened to some interesting statistic about how many American presidents entered office having lost children. At one point, it wasn't a given that you would outlive all of your children. That was, as you say, 100, 200 years ago, was just a terrible, unfortunate tragedy of a life's journey, but it wasn't an insular event. it was kind of more broadly experienced. So interesting. All right, great. Well, that was a lovely conversation on end of life and melanoma. And I think unless you have anything else to add, maybe that's a wrap.
No, thank you.
Okay. That was long.